James Lindsay here from London, and I'm here with Peter, and we're going to do the CornerStones Best of DDW program for you. We're going to start with a little introduction before getting straight on into some of the abstracts. Of course, as many of you who have been at these kind of meetings before will know, this is an independent activity, but it would not be possible without the support of educational grants from our funders listed here: AbbVie, Amgen, Bristol Myers Squibb, Celltrion Healthcare, Galapagos Biotech, Janssen, Pfizer, Takeda Pharmaceuticals, and Tillotts Pharma. They have no input into the content of the meeting, but as mentioned, their support ensures its continuity. And then for those of you who haven't been to a CornerStones Best of DDW in IBD before, I'm going to spend just a few moments introducing the concept. The idea is that a group of faculty and fellows get together before DDW and screen all abstracts in inflammatory bowel disease, all the presentations, all the posters, to identify which might have clinical relevance moving forward, what's novel, what's new, what's interesting, what's well done. So that after that initial screen, the abstracts, several hundred of them, are divided up between groups of fellows and faculty who attend the presentations, or in this case, the virtual presentations and the posters. They communicate with the authors and they create a slide set. After DDW, we all get together and we vote on which we think the most impactful abstracts are, and then that generates the slide set that you can download from the handouts. Fair to say that Peter and I do select a potpourri of those abstracts that we think are most relevant to the UK audience. This is the screenshot because, of course, rather than meeting in person, it was all done by Zoom. And just to highlight the faculty, it's led by the directors Marlon Dubinsky and David Rubin. There's a group of US faculty, faculty from Australia, New Zealand and Asia, many of whom will be familiar to you, and then, of course, Pete and I. But most importantly, the fellows. These are the people who effectively do all the work. They communicate with the authors, they get the index data, and they create the slide set. And a call out to the UK fellows, Hannah and Susanna, who put a huge amount of work into making this program happen. We're now going to kick off, and you'll see that the presentation, which will last exactly no more than an hour and a half, will finish dead on, if not just a little before 8 o'clock, is divided into a series of topics. And as mentioned, we'll break at the end of a couple of topics, just so that if there are any questions, we can ask them while they're still fresh in your and our minds. So with that, I will kick off, and here's Peter introducing the first abstract from the program.
Thanks, James. So you can see this section covers a bit of a range of areas, and we're going to start off with one which I think is kind of nice abstract, this, because it demonstrates the utility of the multidisciplinary team in quite an effective way, I think. So it's a program called COMPASS IBD, which is basically that patients who have recently been diagnosed with inflammatory bowel disease are introduced not only to their IBD specialist, but also to a nutritionist, by which I think they mean a dietitian, a behavioural health specialist, a pharmacist, interestingly no nurse in there, but basically it's a comprehensive team, and importantly, they're also given a care programme, an idea of how their disease should be managed and how to deal with it. Anyway, so this study looked at about 180 patients, half of whom took part in COMPASS IBD, and half of whom who were also from the same centre, which is Mount Sinai, New York, were the controls. And there wasn't any great difference between the two groups in terms of their baseline demographics and their clinical characteristics. But what was different was some of their outcomes. So after controlling for things like sex, age, disease type, surgery, etc., you can see that the COMPASS IBD patients, if you look over on the right-hand side here, were slightly more likely to be in clinical remission, although not statistically significantly so. Interestingly, and here I think we have to take note of the input of dietitians. They were more likely to have a normal BMI, although of course it could be other things that inputted that as well. But perhaps the most impressive data here is they were significantly less likely to attend the A&E department or end up in hospital. If you look at that difference in the bar graph over on the right, only about 15% of patients who were in the Compass IBD group ended up coming to hospital or being admitted, but it's something like 40% in the patients who were in the control group, so about 4 times as likely there.
I think that's really interesting, and I guess I'd like to drill down into a little bit more detail about what those A&E visits were. Or how many were A&E visits? How many led on to hospitalizations? Was this really a surrogate for the fact that if you have a way of getting in touch with your IBD team, you're less likely to attend A&E because you will have answered the question with a telephone call, for example? Clearly, that data we know from the sort of IBD nursing helpline in the UK. And
I agree. It's incredibly interesting. It almost doesn't matter in some ways because. No. Whatever, if you look at the A&E attendances in the UK at the moment, driven by COVID, sort of an inability, like you say, to access care due to COVID, anything we can do to decrease that would be a benefit. But it might also be something about disease prevention. I suspect it's less that, but still. On to Alzheimer's disease. So this is, those of you who attend DDW and attend our webinars, will know that these sort of big commercial database trawls are commonplace at DDW. I think this is one of the more interesting ones. So it's looking at the incidence of Alzheimer's disease in patients with inflammatory bowel disease, looked at a cohort of nearly 1/3 patients, slightly more Crohn's than UC. And those amongst those 1/3 patients, nearly 2,500 patients subsequently developed Alzheimer's disease. If you look over on the right-hand side there, you can see the risk factors for developing Alzheimer's disease. Perhaps unsurprisingly, age of greater than 65 comes out. Ulcerative colitis comes out, although you can see the odds ratio is not terribly high. But look at Crohn's disease, about 3 times more likely to develop Alzheimer's disease. And if you don't have Crohn's disease, hypertension, you would expect, alcohol excess, you would expect as well. The thing that I wonder here is, why is Crohn's disease higher than UC? The fact that hypertension is in there makes me wonder some of this isn't Alzheimer's disease. Perhaps some of it is vascular dementia. And maybe that's the Crohn's-y thing here. In some ways, Crohn's is a slightly more vascular disease, I think. If you think back to all the sort of, the original days of thrombocytosis being an original sign in Crohn's disease, I wonder if it's that. But interesting and a bit concerning as well, I think.
Yeah, I think so. I mean, of course, one of the criticisms of these kinds of database trawl type studies, however big and good the database is by definition, your population is a biased population, because it's those who've got insurance can go to the Cleveland Clinic, which by definition won't be the entirety of the population in the Cleveland Clinic area. And of course, the other thing is the diagnosis. How clear cut are we that the diagnosis was Alzheimer's, as you mentioned, rather than another cause of dementia? But of course, it does fit in with a population-based study that was published in Gut earlier this year, showing an increased risk of IBD and all type dementia. So I think we have to say it does sort of fit with that.
And although, as you point out, IBD patients like this will be more closely monitored, and that might increase the risk, doesn't explain the increase in Crohn's disease that we don't really see in UC.
Yeah, no, it doesn't. And I guess that might obviously therefore be a real finding. I'm going to move on to some more database studies. And I think these are really interesting. Many of you will know that there is a particular interest at the moment in the role of food additive emulsifiers in the etiology and risk of flare of Crohn's disease. And this stems from some amazing work done by Benoit Chassang in animal models, showing that specific food additives, particularly carboxymethylcellulate, polysorbate 80 and carrageenan, are associated with shifts in the microbiome. Those shifts in the microbiome drive changes to the thickness of the barrier, mucus barrier, and increase bacterial encroachment into the lamina propria, and increase risk and increase severity of inflammation in animal models. And on the basis of that, there has been an interest as whether the increased incidence of inflammatory bowel disease that we've seen over the course of the last few years, initially in the Western world, then moving into the Middle East more recently, is associated with changes of diet and the near ubiquity of these emulsifiers in our diet. And so we're going to look at 3 different abstracts here. And so first of all, on the left, we're looking at the pure cohort. This is an observational cohort across Europe, taking place between 2003 and 2016. It includes 21 countries, over 110,000 patients, 1,000 people aged between 35 and 70, and habitual food intake is assessed using a food frequency questionnaire modified to that country. And out of those 110,000 people, there were 467 incident cases of inflammatory bowel disease, significantly more colitis than Crohn's disease. Clearly, these were people who developed disease later in life, because the age of the participants was between 35 and 70. But what you can see in the sort of arrows below is looking at the number of servings each day of food that was supposed to contain a food additive emulsifier. And you can see the increasing odds ratios on the left-hand arrow for inflammatory bowel disease as total, in the middle arrow for Crohn's disease, and in the on the right-hand side for ulcerative colitis, that as you increase exposure to food thought to contain emulsifiers, you increase the risk of incident inflammatory bowel disease, particularly Crohn's disease. On the middle graph, you have work from North America, combining data from a series of very well-studied cohorts, the American National Nurses Health Study 1 and 2, which contains predominantly women, the Health Professional Study, which contains predominantly men. And this was an enormous study looking at 5.5 million years of follow-up. During this study, patients did fill food frequency questionnaires in, but not as frequently as during the PURE study. And again, they found a number of incident cases, again, slightly more colitis than Crohn's disease over the course of the study. And what you can see here is, again, particularly for Crohn's disease, an increased risk of developing disease in patients with high ultra-processed food intake, with a ratio of about 1.2. So perhaps not as strong as the signal from the first study. I think there has to be a bit of a health warning with these kinds of studies, and that health warning comes from the quality of data that you can get from a food frequency questionnaire. One of the things that we found out during our research into food additive emulsifiers is that there is a great difference in the amount of emulsifiers in a particular series of products. And so a food frequency questionnaire really asks you which types of food are people eating. And the assumption is that all the same type of food would be as equally likely to contain emulsifiers. But what we found out is if you take a food type like salad dressing, there are salad dressings that contain very high levels of emulsifiers and salad dressings that contain none at all. And so you have to be a little bit careful about the assumption that the food frequency questionnaire is an appropriate way of assessing that. Finally, on the right-hand side, this is a very different type of study. This is the Enigma study running between Australia and Hong Kong, and it's a case-control observational study of patients with a known diagnosis of Crohn's disease and comparing their recall of early life processed food intake to those other members of their household and first-degree relatives who don't have an inflammatory bowel disease diagnosis. Clearly, this kind of study is at risk of recall bias, but it does include a group of people who develop Crohn's disease at an age that we're more familiar with, whereas obviously the 2 studies on the left only really deal with adult onset disease. But as you can see here, Crohn's patients are more likely to recall eating processed meats and processed fruit than their first-degree relatives, and more likely to have consumed fast food. So, I mean, as I say, all of these kinds of studies don't answer the cause or effect type question, but it does support the concept of a role of emulsifiers, and particularly the CMC, polysorbate 80 and carrageenan in the etiology of inflammatory bowel disease.
So it's sort of, I mean, part of that is about risk of developing IBD, but the real question is, if you can alter these things in your diet, is that any use either to prevent and or to treat inflammatory bowel disease?
Absolutely. And so there are studies of a carrageenan-free diet in ulcerative colitis, very small, some signal of benefit. And as many of you will know, we're currently doing a sham diet controlled low food additive emulsifier diet in patients with Crohn's disease. It will be about 190 patients, so it will be the largest dietary intervention trial so far in inflammatory bowel disease, looking to see whether you can impact disease activity by reducing intake.
DDW 2020.
Oh, 2020 quite a bit, I think. Had a bit of a pause during coronavirus. But that's in collaboration with the great dietetic team at King's, and really we're back up and running with that. Oh, another dietary abstract. There has been really, I think, if you look back over the last 3 or 4 years, there have been some really interesting diet studies published. There was the Crohn's disease exclusion diet in children, looking at partial nutrition. There's the CD treat diet from Glasgow, and this is the CD Dine study from North America from Jim Lewis. It's a really interesting study which has got some amazing strengths and, to my mind, a couple of key weaknesses that we need to explore. And this is a dietary study looking at people with Crohn's disease who have mild to moderate symptoms and randomizing them to either the specific carbohydrate diet or to the Mediterranean diet. Now, the specific carbohydrate diet is high in unprocessed meats, poultry, fish, other sources of protein, and it's low in grains, dairy, and sweeteners other than honey. Compared to the Mediterranean diet, which I suspect we're more familiar with, is high in oils, olive oil, fruits, vegetables, nuts, and cereals, and low in red and processed meat and sweet foods. Now, the major strength of this study is that it was a prepared food study, i.e., patients, once randomized, were provided with all their food from a central kitchen, and so the adherence and also the ability to say that a patient on the specific carbohydrate diet was actually getting it is obviously much higher. So that's a real strength, and that was continued to the primary endpoint at week 6. To some extent, to my mind, the weakness of the trial, I guess another strength is it included 190 odd patients, really big trial, 90 in Mediterranean diet, 99 in specific carbohydrate diet. But to my mind, the weakness of the trial is that the entry criteria were based upon symptoms and symptoms alone. There was no objective assessment of inflammation as an entry requirement. And so you get the fact that about 50% of people on the specific carbohydrate diet and just under that 40% on the Mediterranean diet had evidence of active inflammation as measured by a CalPro of greater than 250 or a CRP of greater than 5. And so effectively 50% of people had functional symptoms and 50% of people had symptoms that probably related or may have related to active disease. And of course that makes it rather muddy to work out who got better and who didn't get better. But here on the right hand side you can see the pivotal results, which was about 40 to 50% of patients with either diet had symptomatic remission, standard Crohn's disease activity index less than 150, clinical remission, which included biomarkers, and response in terms of fecal calprotectin or CRP. So yes, interesting, and I think, you know, again, showing the power of doing fed studies, but to my mind, a disadvantage that a mixed population entering into it.
I think it's amazing they went to the trouble of doing this trial, particularly the feeding part of it, and they didn't put a placebo control arm in there.
Yeah, I mean, of course, sham diets are really hard because with a sham diet, you have to alter as many things as the other diets do within your diet in order to make sure that you are appropriately blinded, but at the same time make absolutely no difference to normal nutrient intake. It takes quite a bit of designing.
But easier when you're feeding.
Yeah, I guess so, yeah, because you just make them.
Exactly.
Yeah,
and if you liquidize it all.
Yeah, no, they don't do that.
That's my idea. Well, I'll ask Kevin. Okay, so obesity and Crohn's disease. There's always been quite a lot of interest in fat and Crohn's disease over the years, fat being potentially a pro-inflammatory part of our anatomy. And this looked actually at 5 large prospective cohorts from across the world, from 9 different countries overall. So not just the Nurses' Health Study, which always comes up in DDW, both 1 and 2, but also the big Swedish study, the EPIC, which is run in part from the UK. Anyway, lots of patients, and I think probably the biggest number we've ever seen in Best of DDW, over 10 million person years of follow-up, with just about 550 cases of Crohn's disease, double that pretty much of ulcerative colitis. And interestingly, there was no observation between obesity and the risk of ulcerative colitis. But if you look over on the right-hand side of the results table, you'll see that if you look at the baseline BMI of patients with Crohn's disease in table 1, there was an association once you went to multivariable analysis, at which point adjustment had been made not just for age and sex, but also smoking status, physical activity, etc. You see there's an association between having a BMI of over 30 and the development of Crohn's disease. And indeed, if you look at it by sort of each change of 5 in your BMI, then the relative risk increased by 1.16. If you then go on actually and look at BMI in early adulthood, so as you can see here, BMI at the age of 18 to 20, the risk is even greater. So now you get hazard ratio of about 1.5 by the time you have a BMI of 30 in your late teens, early 20s, of subsequent development of Crohn's disease. Maybe it's all down actually. These people are eating diets that have got lots of food additives in them. That's why they're obese, because they have a crap diet, and that's association.
And I was just wondering what the recall bias of your BMI at age 18 to 20 is, because of course these are patients who are recruited in adulthood, and the baseline is table 1. Table 2 is presumably their recall, unless they required a documented evidence of BMI 10 to 20 years earlier. But anyhow.
Do you remember what your BMI was aged 18 to 20?
My BMI has stayed the same ever since I was at university.
33, goodness me. Right. I don't think it has. More fat. So another way of measuring fat is on CT. You can measure the amount of fat within the abdomen. That's visceral adipose tissue. You can also do this other thing, the Visceral Fat Index, which is, I think, a ratio of your visceral adipose tissue to your subcutaneous adipose tissue. So this is basically 2 studies looking at, first of all, a prospective cohort, the Constellation study in patients who were started on either infliximab, vedolizumab, or ustekinumab, and looking at primary outcome here being steroid-free remission at week 14, and 126 patients there. And there's also a retrospective study of patients who are starting anti-TNF, looking at those 2 indices that I've just described, looking first of all at response, and secondly at risk of surgery. And you can see about 180 patients in each group.
So this is the measures taken at baseline.
Yes, CT
response.
Yeah, absolutely, absolutely. Sorry. So a couple of things that they found. First off, that your anti-TNF response is lower, certainly in some patients who have high visceral adipose tissue. Although you can see in figure 1 there, it also drops off. It's almost like a U-shaped, or the opposite of U-shaped, I guess, an N-shaped curve here in terms of visceral adipose tissue. But then if you go on and you look at figure 2, you'll see that steroid-free remission at week 14 in the prospective study, a deep remission at week 30, and also endoscopic remission seems to fall off in those patients who have higher visceral adiposity.
Oh, I see. So this is like effectively quartiles of visceral adiposity,
right?
Other thing,
and you get less and less response.
Yeah.
I mean, I think there's a few potential explanations about this. One might have to do with pharmacokinetics and distribution.
Absolutely, because didn't the Pence study show that patients who were obese had lower drug exposure?
Right, but the other part of it might be to do with that whole thing about fat being pro-inflammatory.
Yeah.
And it might be a combination. How does it help us? Well, I guess, one of the really good things that came out of PANTS was measured drug levels early, because you can identify people quite early who have low levels and you can intervene. And I guess, we should probably do that across the board. Maybe if you have patients with a higher BMI, you might be more tempted to do it, but I think you can probably do it in everyone. But it highlights another group at risk.
Okay, and I think this may be the final one in this section, then we'll break for questions. This again was, I think, a really interesting study. It came from Cedars-Sinai in Los Angeles, and it was looking at what the impact was of patients in whom initially they had a diagnosis of ulcerative colitis, but subsequently, because of investigations, because of outcome, they were found to have a diagnosis of Crohn's disease. And they're called the UC-CD switchers. And they were compared to people who continued with a diagnosis of ulcerative colitis throughout, or patients who started with Crohn's disease and continued with Crohn's disease. Importantly, this did not include anybody who'd had a colectomy for ulcerative colitis and subsequently was diagnosed with Crohn's disease because they, for example, developed small bowel disease. They were not included. These are people who are surgically intact from a UC perspective. And you can see they had just about 330 patients initially UC switched to Crohn's disease versus 2,000 and a bit UC patients and 3,500 odd Crohn's disease patients. And there are some quite interesting factors, perhaps as you would predict. People who switch from UC to Crohn's disease are more likely to be smokers than those who keep with the diagnosis of UC all the way through. On the table on the right here, something that I thought was quite interesting is that those that switch are more likely to have extraintestinal manifestations. And here you can see switchers compared to those with UC all the way through, an odds ratio of any extraintestinal manifestation of about 70% more. But then you can see sort of fivefold increases, particularly with ophthalmic and pyoderma gangrenosum. And then if you look at the UC to Crohn's disease switchers versus Crohn's disease throughout diagnosis, again, a slightly less marked but increased risk of extraintestinal manifestations. Here on the graph, we have their antibacterial serologies, very commonly done in the US, very less commonly done in the UK, but ANCA perhaps is the only one we may occasionally do. And the UC Crohn's disease switchers seem to occupy a position somewhere between ulcerative colitis and Crohn's disease in terms of ANCA positivity, UC obviously being higher than Crohn's disease, and perhaps the reverse here you can see with ASCA, the exact reverse, again, as you would expect. They also did genotype their patients, and patients with UC switching to Crohn's disease were more likely to have, for example, NOD2 mutations than those who stuck with UC throughout. And finally, there seemed to be a higher risk of primary non-response to anti-TNFs in patients who switched from UC to Crohn's disease than in those who were Crohn's disease through and through, but not with ulcerative colitis. So I guess what this is highlighting is that patients who you see who are switching, who switch diagnosis, they may have an increased risk of extraintestinal manifestations. I guess that might be driven by smoking, but they may be less responsive to treatment. And I guess that might have relevance for clinical practice.
Yeah, I mean, we use so many drugs in both conditions nowadays that, I guess it matters less than it used to. But it is always, it's always interesting the sort of colectomy situation as well, that risk of pouchitis. That's where the serology, well, it's never really proved to be terribly useful, has it? But
I don't think so. And as you know, we don't use it. Oh, sorry. One we go to questions. This is a very straightforward one, actually, and it highlights a point that I think we're probably familiar with. But this is looking at that drive inflammatory bowel rectal cancer, and it's a retrospective study, so obviously some issues with potential data. A colorectal cancer surveillance program over 23 years. looking at just over 550 patients, of whom only half had ulcerative colitis. I think that probably lower times, just over 4,000 patient years, in whom 3% of patients had advanced neoplasia at baseline, and increasing to 6% during at some stage during follow-up. And the sort of factors that you might predict would be associated with the development of advanced neoplasia: having advanced neoplasia at baseline, clearly; having any form of adenoma at baseline, clearly; older age. This has all been shown in the St. Mark's cohort. But the sort of new thing here, as it were, is patients on long-term prednisolone, both in the urovariate and the multivariate analysis, would appear to have an increased risk of the development of advanced neoplasia over time. And I guess that just reflects the fact that they're likely to have poorly controlled disease, I suppose.
I think so. And do you know, if you're looking for a message from this abstract,
don't use long-term prednisolone.
Right, exactly.
Yeah, interesting. This didn't show that primary sclerosing cholangitis was a risk, which I guess might be a slight health warning on the data. Right. Okay, I think we should just have a quick look and see if there are any questions. I'm just trying to, here we go. Yeah, we do. Gosh, we have a lot of questions. Okay, we'll work our way through a few of these. So does the value of an ANA titer due to 5-ASA have any relationship with serological markers, such as ASCA, ANCA? I'm not sure about that.
No, I'm not sure either. Vasu, you've stumped us there.
Yeah, I mean, I don't normally think of, I mean, you probably mean ANCA, but I don't really think of 5-ASA as causing an ANCA positivity.
No.
In the UC to Crohn's disease switch paper, what defined the switch? Yeah, that's a really good question. And actually, I don't know that I don't know the answer. I think it could be histology in a number of patients, and it could be the development of small bowel or fistulizing disease, but I don't know the exact percentages, and Pete is just looking at the abstract for me now so that I can come on to that. A question about diet. Is this effect independent of the sugar, fat, and calorie content of these foods? I.e., did the individuals also have different total fat and sugar intake? Yeah, I mean, so that is a really important point. And of course, it's one of the problems with this kind of data. It's food frequency questionnaire data. So, you know, it's what you have eaten in the recent past. It's not what you have necessarily been eating all your life, although of course obviously it was done at baseline and then followed up. The data will not, I'm sure, have been corrected for all other aspects of diet, although some of them will have been entered into the multivariate model, but I have to say, Paul, I don't know which ones were.
The way they made the diagnosis of a change, they say, was based on stringent clinical, colonoscopic, and histologic criteria of the original diagnosis, but later classified as Crohn's.
Yeah, so I suspect that effectively is sort of almost sort of expert opinion, and they've done a sort of database trawl. Disease activity association and dementia, I think that is really important. Does it run alongside disease activity? I'm now trying to remember the paper in Gut that was published earlier this year, looking at all dementia rather than just Alzheimer's.
The trouble is, when you have these database trawls, it's incredibly difficult to assess disease activity over time, because they either come from primary care and you end up using surrogates which are not necessarily very good, or they're from database claims or claims databases, and you know, you're starting to look at use of medication, but of course that's not the same as disease activity. It could be the opposite. So as far as I know, it's not been done, but as always, it's a very good question.
And to the final point, just a point there, which is entirely correct, which is that there are some ancestral and genetic markers that are associated with bowel disease. So that's at the moment, but we will have another look in just a moment, and then we're going to move on to the sort of treatment type part of the presentation, and I think the first is likely to be Pete's.
Yeah, okay, so tofacitinib we've had available to us now since about 2018, I think 3 years or so, and so we're starting to get larger real world cohorts, and several of these are presented here. We have a retrospective cohort from David Rubin in Chicago, a Leuven cohort at number 2, and then a couple of systematic reviews, one of 2,000, one of 700 patients. I think what's interesting, if you look at the Chicago and the Leuven cohorts, you can see that these are refractory patients. Nearly every single one of them has been exposed to anti-TNF. Not surprising in America because that's the label, perhaps more surprising in Belgium, although our cohort is almost entirely anti-TNF experienced. And you can see that if you look at the clinical remission rates in the Leuven cohort, about a third of patients are reaching remission between about 4 and 6 months in that cohort. But they also looked, both in Chicago and in Leuven, at endoscopic and histologic remission. In Chicago, they didn't really scope many of them, 9 of 14
Pretty small numbers
had remission, absolutely, and you can see about a third of them had histologic remission. By the fact that about 30% of them went on to colectomy. I can tell you that we scoped all of our cohort at about week 14. So I think we've probably done it in about 40 patients now, and we're seeing a Mayo score of 0 or 1 in about 50% of patients by then. So, you know, I think there's little doubt that the drug is effective in these refractory patients. There was a little bit of safety data here. I think you have to be really careful about safety data in these cohorts because, of course, it's not collected in any way the same rigor as in the clinical trials. But you see zoster does occur, not very commonly. Normally you can deal with it. There's one thromboembolic event. Who knows what that means? And serious infections are rare. Abnormal lipids we see, but of course they're relatively straightforward to deal with.
And I guess one thing is, you sort of look at that data, is there's sort of agreement across these studies with different methodologies in terms of remission rates between 30 and 40%. This obviously is a treat-through cohort. This is not like randomized responders that were seen in the clinical trials.
Right.
So effectively, I mean, you know, and although you may say, gosh, that's awful, actually, I don't think that's that bad. About 40% of patients in clinical remission, you know, that's as good as we see with many drugs.
Most of these patients are multiple anti-TNF failures.
Yeah.
By the way, I said there was one thromboembolic event, 0.3 in 2000. That's not one. There were a few thromboembolic events there. And remember, again, of course, these are patients with active inflammatory bowel disease, which will drive that risk as well. And then on to filgotinib, which is a JAK1 selective JAK inhibitor. This is the selection study, which is phase 2B and 3 studies. Looking at fairly standard patients with ulcerative colitis, starting filgotinib either on placebo, 100 or 200 milligrams. Over on the right-hand side here, you can see at the top the induction studies. On the left-hand side, you can see the biologic naive patients, and on the right-hand side, you can see the biologic experienced patients. So 2 things to note, that there appears to be a bit of a dose response here, but that the 100 dose doesn't reach statistical significance either in the biologic naive or the biologic experienced patients in the induction study, whereas the 200 milligram dose is superior to placebo. When you go down to the bottom there and you look at the maintenance study, you can see that there is a significant difference both with the 100 dose and also with the 200 dose. So definite signal for efficacy here. The higher dose appears to be more effective. And importantly, of course, side effects we need to think about. We know there's a zoster signal with tofacitinib, perhaps slightly less of a zoster signal here with filgotinib. I think the fact that we saw 1 PE in 1,300 patients probably tells us nothing at all. There is a hope that the more selective JAK inhibitors may not have the VTE side effects associated with tofacitinib, but I think we have to be very careful about drawing any conclusions from these relatively short follow-up studies of 1,000 patient years only.
And a couple of observations from me. One is that people might say, gosh, those remission rates at induction don't look very high. But let's not forget, this is remission, and this is using a Mayo score for remission. So this is combining both clinical and endoscopic markers of remission.
And it's at week 10.
Yeah, and it's early. And then can I just ask, because obviously the maintenance study, the primary endpoint is remission at both week 10 and week 58. Was it a randomized responders? I think it was.
Yes, but it was quite complicated how they did it. And I think if you stayed, stayed within your category, didn't you?
Absolutely.
So if you were in 100 and you responded, you stayed in the 100 group.
You were then randomized to 100 or placebo. If you were in 200, you were randomized to 200.
And then you could escape to 200, I think.
Yeah, you're right. So it is a randomized responder, but everyone stays on the dose all the way through, irrespective. Yeah, absolutely. You're right. Yeah.
That was a difficult question. So I don't remember that. And then more safety data here, delving a little bit more into this cohort. As I say, over on the right-hand side, we see one VTE event in a 200 treated patients, 2 cases in the placebo, 3 events. I mean, to my mind, if you have patients with ulcerative colitis in a large clinical trial program, you are going to see venous thromboembolism.
Irrespective of whether the drug has any impact on cause.
Right. The fact that you see more cases in placebo here is consistent with what was seen in the tofacitinib trial, and I believe that's because active disease is more likely to cause venous thromboembolism, and because the drugs work, they decrease the risk of venous thromboembolism. But that doesn't mean there is no VTE signal, and we need longer term data to understand that. And again, I mean, there's just a hint of a herpes zoster signal at higher dose here, isn't there?
And we saw that with tofacitinib.
We did see that.
And I think that's one key thing from the small molecules, which is that, there is clearly an exposure-response relationship, i.e. the more drug you use, the better the outcome. But there's also a side effect exposure response. The more drug you use, the more likely you are to get side effects, which of course is not actually the same with biologics, where there's an exposure response, as in more drug exposure, better outcome, but there isn't always a side effect exposure. So we have to be careful about not only escalating our JAK inhibitors, but de-escalating as well when we can from a safety perspective.
And we know this with azathioprine.
Yes, of course. Right. I mean, that's exactly. Exactly. Okay, so I'm going to now just tackle some of the data on one of the other new MOAs that we're going to be seeing coming through, and these are the Sphingosine 1-phosphate modulators. Now, Sphingosine 1-phosphate has several subtypes. We're particularly interested in those that impact the migration of newly differentiated effector memory lymphocytes from the draining mesenteric lymph nodes back into the circulation. So effectively, drugs that impact S1P act to cause retention of these newly differentiated inflammatory effector T cells that have differentiated in the gut from getting back into the circulation. Important to say this may not be the only MOA, because many other cell types express S1P. Anyhow, they are approved currently for multiple sclerosis, fingolimod and ozanimod, and they are under investigation for inflammatory bowel disease. That's amiselimod, ozanimod, and etrasimod, and they all have slightly different specificities for the different subtypes of S1P, S1P1, S1P15, or S1P14 and 5. This is the ozanimod data. It's the True North study looking at patients with moderate to severely active ulcerative colitis randomized to receive either ozanimod at a single dose or placebo. And this is the induction data. This was actually presented at UEG, but was also presented at DDW. And what you can see, again, a really early early time point to be looking for remission, because of course in UC, where you're looking at the Mayo score, you have both clinical parameters but also endoscopic parameters, and these are quite tight definitions of remission. You have to have had some endoscopic improvement. Anyhow, a clear signal of benefit, a delta of about 12. And if you look at response, again, clear signal of benefit, delta of about 21, and going over endoscopic improvement, which is reduction to a Mayo score of 0 or 1, or mucosal healing. So this is a clear signal of benefit of ozanimod, 1 milligram once daily compared to placebo. And the data that I think is new for DDW, wasn't presented at UEGW, is the onset of action data. So this is looking at the partial Mayo data, rectal bleeding subscore, stool frequency subscore from patient's diary, as well as some CRP calpro markers, looking to see how quickly patients treated with ozanimod improve compared to patients treated with placebo. And you can see here, looking at stool frequency, this is the blue is the ozanimod line going out over time to week 10, and the gray is the placebo arm. You get a significant difference at week 4. And if you look at rectal bleeding subscore, that difference is even earlier. So by week 2, you can see clear differences between the groups. And that's fast. That's certainly as fast as the data from tofacitinib. So they work quite quickly. And then looking here at week 10, in terms of biomarkers, you can see patients here, calprotectin, a significant fall in calpro, no difference with placebo, similar with CRP. So I think we can say, relatively fast onset of action.
Tofa has data at day 3.
What does it have at day 3?
Yeah. I mean, it might well do, but that's not presented. Anyway.
This then is the maintenance trial. So in True North, as in many of there are trials, patients who responded to induction were re-randomized to either placebo or to continue on the same dose, because there was only one dose of ozanimod. And again, here you see very nice data with clear significance across all endpoints studied. Let's just take clinical remission here. Upwards of 40% of patients in remission, a delta of just about 20% above placebo. And if you then look back to Peter's data from the tofacitinib, now clearly this was not quite as treatment refractory group, but the order of magnitude is much the same. I think there is one more data on ozanimod. We'll do this really quickly because again, it's a slight subset of the data, not subcut. It's an oral drug, and it's the data from the True North study. I've shown you the primary induction and maintenance endpoints, but this was just highlighting the steroid sparing effect. So looking at corticosteroid-free remission at 52 weeks, you can see, again, significant benefit over and above placebo. So I think we can see that this, I think, will be a trial that will, a drug that will reach clinic. I think it is important, again, when you look at a new class of drug, to consider safety, and there are some key safety things to consider. I think the first thing to say, of course, is that ozanimod and drugs in this class are in general a very safe class of drugs, but because of its mechanism of action, retention of lymphocytes within the draining mesenteric lymph nodes, pretty much everyone gets some form of lymphopenia. What's not clear, certainly to my mind anyhow, here you can see this abstract is data from the phase 2 trial, that was called Touchstone, and the phase 3 trial, which is True North, looking at just over 1,000 patients, nearly 2,000 patient years treatment. And what you can see is pretty much all patients develop some form of lymphopenia, but whether there is a direct link between that and development of infections, I don't think has been actually made with this class of drugs. We know from other drugs that cause lymphopenia, for example, azathioprine, the more lymphopenia, the higher the risk of infections. You might assume it will be the same here, but I think we just need to see data to show that. A couple of other things that I think are worth pointing out. A bradycardia, there is a very small decrease in baseline heart rate. I think it's of the order of 1 or 2 beats per minute. Of relevance, because people with known cardiac disease need to have an ECG before starting it to exclude heart block. Macular edema, incredibly rare but recognized side effect of etrasimod, and people who are at risk of macular edema, i.e. have had a previous history or have diabetes will need to have an ophthalmology review before starting it. So it won't be quite as straightforward as some, because there will be these additional requirements. But of course, we're used to that because we're used to doing quantiferal tests in people before we start an anti-TNF. So it's a sort of similar type of thing.
And the other thing is, sometimes things change with time, don't they? As I said to you last time, when I was a house officer, we used to admit people to start them on an ACE inhibitor.
Yeah, I know. Yeah. So things will change.
Good. Okay. A little bit of a summary study here. This is looking across the not very many studies that report the effectiveness of tacrolimus as a treatment for pouchitis, perianal Crohn's disease, and proctitis. And of course, I mean topical tacrolimus here as opposed to oral tacrolimus. So there's been a few good studies out. I think Ian Lawrence it was, didn't it?
One from Australia, one from Leuven.
Of tacro suppositories in refractory disease. They're not terribly easy to get hold of, but you can get hold of them. We use tacrolimus ointments, a reasonable amount actually, for perianal Crohn's disease. And then there are indeed tacrolimus enemas as well. So this is looking across the 11 studies they could find, looking at about 200 patients. And you can see that if you look at the remission and response rates that they describe here, you get a pretty good response from tacro. And I think that kind of rings true, actually. You know, when we use it, it tends to work. I think the key with this is, you know, what the risks of it are. You can see that, in fact, nephrotoxicity occurred in a single patient. I don't know how rigorous they were about collecting the data, but still, out of 200 patients receiving tacro, that is a low rate of toxicity.
You obviously get some systemic absorption.
Right.
Thing that I'm not familiar with is the use of tacrolimus in chronic refractory pouchitis.
I agree.
I've never tried that, whereas I have tried tacrolimus in ointment in perianal Crohn's and suppositories in patients with proctitis.
Yeah, but it might be worth a go. Should
we have a quick peek at questions? Which way does it go? Oh yeah, okay.
A little bit more.
Yeah, here we go.
No.
So this is a question taking us back to the UC Crohn's disease switch. Why isn't it simply a case of mislabeling? Or to put it differently, if inflammatory bowel disease is to be seen as 3 conditions on a spectrum, then surely we should expect more switching, as it were. And I think that's absolutely right. Of course, you know, colonic Crohn's behaves more like ulcerative colitis. Small bowel Crohn's disease is probably a genetically distinct condition. And of course, these kind of retrospective type reviews, when you are looking back to see changes in diagnostic criteria, you know, could obviously also represent an evolution in diagnostic technique. So yeah, I think that's a very good data. Sarah Langland's here. Any more pregnancy experience with tofacitinib? I think that's a really important question. My understanding, as far as it goes, is that there is, all the data would suggest that you shouldn't become pregnant on a JAK inhibitor, as far as we know. I know of no additional safety data.
No, and I think the reality is we're not going to get good safety data there. And you know, I completely agree. Don't use it and don't use it in breastfeeding. I guess the difficulty is you've got someone who's got pregnant whilst they're taking it. What do you do? And I think the answer is you stop it and you watch the baby and talk about the unknown risk. And of course, that's where you do get a bit of data. In terms of the next question, which is about the impact of filgotinib on sperm quality. So there are some data from animals that suggest there may be an adverse effect of filgotinib on sperm production and quality. There are 2 studies which are ongoing, the MANTA study and the MANTA-RAY study, RAY being rheumatoid arthritis. And the headline readouts from those suggest that, so there's been a press release that suggests that there's no huge problem there, but we need to see the full results of the study. But reassuring, I think, thus far. Yeah. And more data to come.
It would slightly surprise me if there was an impact, because you've got 2 other drugs for which that hasn't been highlighted, which work in a very, you know, upadacitinib and tofacitinib have not had a question from the animal model about sperm quality. And so it would slightly surprise me if there was a real signal there. I think this is a great question of which patients do you think are most suitable for ozanimod? And to some extent, of course, that's going to depend entirely on the cost. Because, of course, if you were to
take cost out of it.
Well, if you take cost out of it, it's an oral small molecule. It's likely to have, as far as we can see, it's got a relatively favorable safety profile. I think you'd put it, I think there's certainly no concerning signals that we've seen, say, with tofacitinib. So I guess you might put it as in someone before an anti-TNF with moderately active disease. But of course, in order for it to do that, it would have to be competitive.
So now
compared to
realistically,
biosimilars. And if it comes in cheaper than biosimilars, and Paul is suggesting here that it's not going to, but I don't know where he gets his information from because I don't know what its cost is actually. If it's inexpensive, it's going to definitely be safer and more effective than azathioprine.
I guess Paul is basing this on the cost in MS.
Yeah. Okay.
So
it's likely to be. So different doses or same dose? Don't know.
But it still has to be anchored to the cost. The other thing is, of course, that the post-anti-DNF data in ozanimod actually doesn't look that bad.
No. In people who were non-responders, it does appear to be pretty much equally effective to bio-naive. Although small numbers, and of course we will need to see that.
Okay, this is a great study. I love it when DDW produces great studies. This is a great study. So you will all remember the story trial, Edouard Louis' study looking at patients who had combination therapy with infliximab and azathioprine, stopping the infliximab and seeing what happened. And about half of them relapsed over 2 years. So he has gone on to do a massive European study called Biocycle and Spare, which looks at randomizing people to continue both drugs or continue one or the other, and then interestingly actually what happens when they relapse and how you recapture. This is slightly more simple, but it's the first RCT to really try to answer this question, and it looked at about 115 patients who'd been on infliximab for about 2 years, half of whom in each arm were using concomitant immunosuppressants. And they were randomized either to continue or discontinue infliximab. At inclusion, they all had CDAIs of less than 150, normal fecal calprotectins, I think normal CRP as well, and then either endoscopic, be that colonoscopic or capsular endoscopic or radiological evidence of disease inactivity. Note, patients with perianal disease were excluded from the trial.
These are quite deep remission patients.
Then. They're in remission. Randomized to continue or discontinue. Look at the graph on the left. The continue arm of infliximab, you might guess, is the top one. They all effectively stayed in remission. The bottom 3 lines are all discontinuation of infliximab. The middle of those is the entire cohort. The top, the green one, are the patients who were on azathioprine. Can they see the cursor? Oh, thank you. Yes, okay. And then the bottom one is the patients who weren't on azathioprine as well. So it shows you, interestingly, I think, that the thing that's keeping most of these people well, of course, is the infliximab. The azathioprine it does help a little bit, but clearly the thing that makes a difference is infliximab. If you look at endoscopic remission at 48 weeks, then you're down to 30% of the patients who withdrew, 90% of the patients with infliximab. As you would expect, some people lose response over time.
And I guess what I like about this is the data pretty much exactly mirrors all the other data that's ever been published in this area, which is that if you stop infliximab in a group of people in a good, stable remission, about 50% of people do well at a year and 50% of people do badly. And you can take that as you want in terms of glass half full, glass half empty.
You don't need to do RCTs anymore. And then this is a UK study, comes from Edinburgh. We've been very familiar with switching patients from infliximab from infliximab originator to biosimilar, and indeed another switch on from there. This is some good data looking at switching from originator adalimumab to Imraldi, one of the biosimilars out there. It's retrospective cohort study from Edinburgh. looking at patients who were switched, and they have data on the IBD phenotype, on the CRP, on drug survival, on antibody levels and drug levels as well, and of course on fecal calprotectin. And we're very good at fecal calprotectin. So the results in 230 patients, if you look over to the right-hand side, red bar is the CRP, and you can see that from baseline through week 26 to week 52, CRP stays steady. Calpro, if anything, you see a decrease slightly in the number of patients who have a fecal calprotectin less than 250, but nothing significant really to see there. And then if you look at the HBI or the partial Mayo score, again, a very slight decrease, which I think you expect to see in time with patients who have inflammatory bowel disease anyway. Drug antibodies were present in about 11% of patients at baseline, 14% at week 26, at 24%, although down to only 33 patients by now at week 52, and about 35, so about a sixth of the cohort underwent a double switch. So they went from Humira to SB5 to another biosimilar, ABP501, because of intolerance, and no antibodies were detected. So I think the message here is probably that the data we have seen, the reassuring data with infliximab, we are probably mirroring in adalimumab.
Yeah. Okay, so now some vedolizumab data. A couple of years ago, we presented the LOVE Crohn's study, which was the mucosal healing in Crohn's study. This is the LOVE UC study, mucosal healing in ulcerative colitis. And this is a well-designed, prospective, multi-center study. It's open label, so all patients got drug, moderate to severely active ulcerative colitis, divided into two cohorts. And I think this is quite interesting. The early cohort all had disease for less than 4 years and were naive to immunomodulators or biologics. And the late cohort had slightly longer disease, greater than 4 years, and had previously either been exposed to azathioprine or a biological, both. Everyone received standard dosing at 0, 2, and 6, and this is an IV vedolizumab study. The primary endpoint was patients in sustained clinical remission at both week 26 and week 52, and they included about 120 patients, evenly split between early and late disease. The late disease people had a slightly higher endoscopic severity at baseline, but there were no significant differences in the proportion of patients in sustained remission at those two time points, and that was about a third in the late group, and numerically, but not significantly, more in the early group, about 40%. And here we've got the endoscopic data, and what you're seeing effectively as we move across these series of columns is time, and the proportion of patients who have the different Mayo scores. So sort of light pink and red are Mayo 2 and 3, and obviously by definition everyone had that at the beginning because they had to have moderate severe disease. And then the green, light green is Mayo 1, dark green is Mayo 0. And so what you're seeing is the evolution of mucosal healing in patients with ulcerative colitis treated with vedolizumab. And as I look at this, I think probably my take-home message is you get mucosal healing, as in Mayo score of 0, 1 in about 50% of patients, and it doesn't seem to matter that much whether they were early or late.
And I think that fits in with the data from the original trial programs as well.
Pretty much like this, yeah. But this obviously had dedicated. And finally, this, we're not going to spend ages on it, but it just shows some of the difficulties in doing trials in the pediatric cohort. This is the pharmacokinetic data, which was effectively what was used to get authorization for vedolizumab in pediatric inflammatory bowel disease. Took a mixed population of less than 18-year-olds with Crohn's or colitis, randomized to one of 2 doses of vedolizumab, and because of course the weight of the patients differed, even though there were high or low dose vedolizumab, there were 4 different doses of vedolizumab used because based upon weight, and the primary endpoint was pharmacokinetic. And what you can sort of see here is that there is an exposure a dose exposure, as you would expect, maybe easiest seen here in red. As you go up the dosing bands, you see increasing serum levels, as you would expect. And then from the efficacy type endpoint, what we're really seeing is that lots of overlap between the different doses, but there's no significant difference in efficacy between the different doses. But vedolizumab is now, I believe, I'm sure, is a licensed therapy for ulcerative colitis.
Okay, another great study. This is Seaview. I'm sure most of you will have heard of Seaview, but this was its first proper presentation. Seaview is the first biologic head-to-head trial in Crohn's disease. We've had one, of course, in ulcerative colitis. In Varsity, we never had one in Crohn's disease. And this compares ustekinumab with adalimumab. So it was obviously multi-center randomized double-blind controlled trial with standard entry criteria for a Crohn's trial, so a CDI of 220 to 450 with some endoscopic evidence of activity. Importantly, patients were biologic naive, failing or intolerant to conventional therapy. They were probably a slightly less bad cohort than we see in many of the Crohn's disease trials, so shorter disease duration, probably a lower SES-CD. I think the average SES-CD was probably about 8 or 9. Most of the big trials you're looking at 13, 14, something like that. And we need to think about that when we look at the outcomes. So randomized either to ustekinumab or adalimumab with placebo injections or infusions of the other drug, so that you didn't know which one you were getting. The dose was the American dose, which for ustekinumab is 8 weekly, and I think most of us use that in the UK as well for our Crohn's patients, and adalimumab every other week. No dose escalation in the adalimumab arm. It was powered as a superiority study between ustekinumab and adalimumab, ustekinumab being powered to be more effective, but you can see it didn't meet its primary endpoint. There was no statistical difference between the two groups. Interestingly, though, you can see remission at week 52 seen in a pretty astonishing 60% of the adalimumab patients, 65% of the ustekinumab patients, and that may be a reflection of the cohorts that were recruited, but it's much better than we have seen in many other Crohn's studies.
And we mustn't forget, this is a treat-through study, so this isn't
it's not randomized responders.
It's not randomized responders.
Absolutely.
So these were all comers, although, as you say, the disease was slightly more mild.
Absolutely. The other thing, if you look on the other side of the graph there, you can see that both drugs work pretty quickly and they mirrored each other pretty much the whole way through the study. Now, because it didn't meet its primary endpoint, secondary endpoints, which we start to see on the following slide, basically the p-values are all nominal. And you can go down these ranked secondary endpoints from steroid-free remission through to a variety of patient-reported outcomes, and you see there's the occasional numerical difference. There's even the odd positive nominal p-value. But I think the takeaway message is there probably isn't a huge difference here between the two drugs. You know, I mentioned some slight differences. If you look down on the right-hand side here, perhaps ustekinumab had a slightly better steroid-sparing effect than adalimumab. Perhaps not. I think one of the interesting things in this study was we got some decent endoscopic data for ustekinumab, which of course we didn't see in the Unity program. It was really just a sub-cohort of patients who were seen there. But I think, you know, we know that anti-TNF is good in Crohn's, don't we? We know that it can heal the mucosa. And I find it reassuring to see here that we see at least similar changes with ustekinumab in this cohort of patients in terms of mucosal healing.
Absolutely. Do we have drug levels for the adalimumab yet?
No.
No.
So the data, the pharmacokinetic data might be available for UEGW. And I mean, you're right. Okay, there was no dose optimization of adalimumab.
Or ustekinumab for that matter.
Although it was at the maximum licensed dose. In the UK, we can go to 40. I don't think that's the point. I think this trial shows ustekinumab is a good drug and adalimumab is a good drug in Crohn's disease. They both cause mucosal healing. There's no dramatic difference between the two. In terms of side effects, and in fact, I didn't really talk about the side effects in Seaview, there weren't any great differences there. Perhaps the only difference was in injection site reactions, which were slightly more common with the adalimumab-treated patients. There has been a little bit of concern with ustekinumab and major adverse cardiac events, which really comes from I think it's the psoriasis cohort actually, and a study looking back showing that people who have pre-existing risk factors for ischemic heart disease are slightly more likely to get major adverse cardiac events with anti-P40. This study was looking at the entire inflammatory bowel disease program and didn't really show a signal here.
Although, of course, most of these people won't have had.
Of course, by definition,
cardiac disease, by definition.
Of course, by definition, they wouldn't. And of course, you have to remember that patients with psoriasis are a different cohort to patients with Crohn's disease.
Absolutely,
a lot more
treated
smoking.
with a different dose.
Right.
And of course, actually, in the JAMA paper, followed up for a little bit longer than they are in the phase 3 trials.
Of course.
Okay, I'm going to present data from the risankizumab phase 3 trial. Now, risankizumab is an anti-P19, so unlike ustekinumab, which blocks both IL-12 and IL-23 signaling, risankizumab purely blocks IL-23 signaling because it's an anti-P19. This is the Advance and Motivate trials. These are the 2 phase 3 induction studies of 2 doses of risankizumab versus placebo in a group of patients with moderate to severely active Crohn's disease. In Advance, they were either biologic exposed or biologic naive, but had previously been exposed to conventional immunosuppressants. And in Motivate, they were all biologic exposed. Standard type of outcomes, total cohort of just under 400 patients, good completion. And what you can see here, this is the combined data of both trials. You can see in the induction endpoints, really nice induction of remission and 30 to 40% irrespective of dose in terms of clinical endpoints. And as you would expect, just slightly numerically higher data in those naive to biologics than those previously exposed. Endoscopic response, again, a nice strong signal of benefit. So this is week 12 data, so slightly longer than we have seen in the initial Crohn's trials, but showing a really nice strong signal of benefit.
I think the endoscopic data here is impressive, actually.
Yeah, so I'm now just looking at the definition of endoscopic response, which is a fall of SESD of 50%. Yeah. And that would be higher. That would certainly be higher than, for example, we saw in the ustekinumab data from Paul Ruckert's sub-analysis of the immunity data, I think.
Right. I think it's quite impressive.
Okay, 2 little abstracts now on checkpoint inhibitor colitis. Really, they're quite straightforward. They're both retrospective and have all the problems with that. This is looking at the impact of vedolizumab or infliximab for checkpoint inhibitor colitis, just under 200 patients, and looking not only at colitis outcomes, but also cancer outcomes. And what you can see is no real difference in the ability of either agent to induce remission. People on vedolizumab seem to stay in hospital a little bit, seem to take a little bit longer to get better, but slightly perversely spend less time in hospital. We don't know about the difference in severity of colitis between these 2 groups. What was interesting is people treated with vedolizumab seem to have a slightly lower relapse rate for their checkpoint inhibitor colitis and a slightly enhanced cancer progression, as in less likely to have cancer progression. And here you can see overall survival with vedolizumab alone at the top here, infliximab alone, the blue line at the bottom, perhaps a signal that vedolizumab patients do better. But you could argue that maybe the patients who were more severe got treated with infliximab.
I mean, who knows? You have to be very careful about comparison there.
Absolutely. And this then, just another abstract looking at a retrospective single center study of 100 patients and comparing patients who had a single shot of either infliximab or vedolizumab versus those who had ongoing treatment after resumption of their immunotherapy. And perhaps, as you might expect, if you have maintenance treatment with your biologic, you're less likely to have recurrence of your checkpoint inhibitor colitis on reinstigation of the checkpoint inhibitor. Just a message there for our oncology colleagues.
Another study which I think you have to be careful about what conclusions you draw here in terms of comparisons. But the thing that's interesting here is the fact it's a study looking at a combination of small molecules and/or biologics. So you can see down the left-hand side there a number of studies looking at combinations of things like tofacitinib, vedolizumab, natalizumab, ustekinumab, etc., etc. I think the important thing to notice, there's only one RCT in here, that's the natalizumab and anti-TNF study, and I think that's of limited interest to us because, of course, we don't use natalizumab anymore. And then when you look at the other studies, there's relatively small numbers of patients in these cohorts, and therefore I don't think it is reasonable to look at differences between clinical remission and endoscopic remission, and indeed side effects between these different combinations of treatments. I do think it is reasonable to note that people are doing this, and I think what we've struggled with over the last 20 years since we've got these new agents is we're hitting that ceiling, aren't we? Yeah. Of whatever 40% steroid-free remission at a year. And certainly for induction, I think the only way we're going to get to really much higher levels, let's see what some of the newer drugs say, but the only way we're going to is by using combinations of treatments.
Or selecting the type of patient who's going to respond to the drug in the first place.
Okay.
I can't do that at the moment. I guess the thing I take over that, and I completely agree, there's no point choosing your strategy based upon this kind of data. But if you look at these people who will have been very treatment refractory, 40 to 50% of patients are ending up in remission. So it's not a pointless thing to do.
A shout out for Seb, who is doing the Combio study in the UK and looking at lots of patients.
So a question from Marcus here about will the controlled trial study of infliximab cessation allow us to continue rather than keep reassessing our patients every year? Of course, it's difficult to answer that, but given that the cost of infliximab is now fallen dramatically, it seems harder and harder to justify discontinuing in patients in whom they're then going to have a 50% chance of relapse, would be my view.
Yeah, there's no restarting data in that study, because if I was a CCG, I'd say, well, look, 50% of patients can stop.
Yeah,
and the rest can just restart, can't they?
I guess you'd have to look at the costs involved with restarting, reinvestigating, hospital admission in some, and of course it may or may not come out.
And I think so. Gareth Walker asking a question here about, does it depend how you got onto infliximab in the first place? And I think that's a really important point. And of course, I don't think that was addressed in the study at all. Absolutely. So we can't answer that question. And I think there's some patients, they excluded those with perianal disease. And I think the message there is there are some patients who you really shouldn't be stopping.
Absolutely. And of course, you don't know whether a person would have included someone with really severe rectal disease. Right. We have 10 minutes left. Okay. We're going to go quick fire.
Quick fire. So next two abstracts are quick fire because they're ultrasound abstracts. And we often put an ultrasound abstract in because we think it's interesting. It is, I think, starting to take off in the UK. And I don't know who it was, but I saw a BSG survey recently on ultrasound and inflammatory bowel disease. There are more and more people trying to get training in it through organizations like IBD. Two abstracts here in Crohn's disease. One from, I think it's from Emma Calabresi's group in Rome, basically suggesting you can start to look at disease behavior. And of course, that's not entirely surprising because you can see strictures and fistulas with ultrasound. So not just seeing active disease, but also what the disease is doing. And of course, it's all beautifully in real-time motion. So you can see strictures. Yeah, it's beautiful stuff to watch. And then, of course, over on the right-hand side, something looking at post-operative Crohn's disease, looking at there's different sorts of ultrasound you can do, like small intestinal contrast ultrasound or contrast enhanced ultrasound. looking at the different sensitivities and specificities of these. The thing that I think is interesting here is we use endoscopy to define post-operative recurrence, and maybe that isn't the best way to do it, actually.
I think
because all that's doing,
I'd rather have an ultrasound.
Well, I'm sure you would, but the other thing is, what does the mucosa actually mean? And maybe actually the bowel wall is actually much more interesting. So I think this needs following up and investigating further. And indeed, this from the group in Amsterdam, looking at intestinal ultrasound in ulcerative colitis, and it's actually pretty good at showing disease activity, and that's not surprising. You can see the colon, perhaps apart from the rectum, fairly well on ultrasound. You can see whether it's inflamed. So instead of scoping people to assess response at week whatever, 10, 14, we could just ultrasound them instead.
And of course, it is now going into clinical trials because the Stardust trial, dose escalation and ustekinumab, used ultrasound as an endpoint. We sort of said we wouldn't have any COVID in this presentation, but this is
COVID?
Yeah, this is effectively saying something we sort of know, is that people with worse disease seem to have worse outcome. And clearly, the biggest driver for poor outcome with COVID, if you've got inflammatory bowel disease, remains age. But if you're younger, active disease is associated with worse outcome. I'm sort of going to leave that there. This is a study, I guess it's telling us something we sort of already know, but in a nice large way. And it's looking at the impact of paternal exposure to immunosuppressants, including biologics and methotrexate, to subsequent pregnancy outcome in their partners. It's not looking at fertility. It's looking at male exposure to drugs and subsequent outcome. Across a range of different diseases, the sort of standard ones, but a good chunk of them, just under 50%, were inflammatory bowel disease. Just under 2,000 patients included, and the conclusion, realistically, you can see here the drugs, 10% on methotrexate, 25% on thiopurines, the majority you might expect on anti-TNF, the others on non-anti-TNF biologics. But realistically, there was no signal of risk in terms of congenital abnormalities, preterm birth or low birth weight. So again, another piece of evidence supporting the fact we don't need to stop methotrexate in dads wanting to give birth, but we can reassure them about the other drugs as well. I think we're now onto the final run.
Yeah, we're nearly there, and we've actually pretty much stuck to time. This is a propensity score matched cohort from two centres, the Cleveland Clinic and another in New York, looking at patients who were given different biologics in the post-operative Crohn's disease setting. I think it said they identified nearly 1,000 patients overall who'd had an intestinal resection, and looked at those, compared ustekinumab, vedolizumab and anti-TNF. Most of them have had anti-TNF, you can see, compared with ustekinumab, which is about 50 patients, and vedolizumab being 70 odd patients, the other having none. The take-home message here is they didn't identify a difference after propensity score matching. Now, if they propensity score matched patients who like 50 odd ustekinumab patients, they probably actually got down to a relatively small cohort, I expect. So to my mind, it says you can use these drugs in the post-operative setting. It's difficult to draw too much of a conclusion about lack of difference. This is an interesting study which looks at the timing of rescue therapy with infliximab in patients who have acute severe ulcerative colitis. 95 patients, 15 underwent colectomy, and you can see here that they split them into different lengths of stay over on the left-hand side here, and you can see those who had a length of stay of less than 7 days on average, the median time to initiation of biologics 3 days, whereas it was more than 7 days, it was 4 days, and you might think that was simply about the timing of the administration of the drug, but in fact it suggests that it wasn't, and that in fact it does actually matter in terms of the day that you give it, what your chance of responding is. And even by 1 day, And I guess the important message here is that time does matter in this situation.
And slightly interesting, if you follow the current guidelines, you assess at 72 hours to make a decision as to what to start at day 4 or 5. So we may not be early enough.
Yeah, although I think actually, I was talking to someone, and in some ways, I think the Travis score is assessed at the end of, I know it's day 3, but I think it's the end of 48 hours.
It is sort of the end of 48 hours.
Yeah. So anyway, give it early.
Okay, so we're done.